Hi, so good afternoon, or I guess we're still in the morning part. My name is Amanda Hardy. I'm a current fourth year and chief resident for MedPeds at the University of Tennessee Health Science Center in Memphis, Tennessee. I will be presenting my abstract titled Airing It Out, Using History to Expand the Differential in the Workup of Dyspnea. I would like to thank my mentor and senior author, Dr. Christopher Jackson, and I'd also like to thank SMA for the opportunity to present my case. And with that, I will go ahead and get started. So it was in clinic when we first met our patient, a 52-year-old female with a history of alcohol use disorder and reactive airway disease, who presented for a follow-up visit to clinic with about 6 weeks of intermittent dyspnea. This dyspnea was associated with palpitations, nausea, and an overall sense of impending doom. But she didn't report improvement with lying down. On further questioning, we of course, asked about exposures, which she denied, and she shared that she really didn't leave home that often. Vital signs during that visit were within normal limits, and after careful discussion and through the process of shared medical decision-making, we arrived at a plan for further workup. So in addition to basic labs, she would leave the visit with a referral for PFTs, or pulmonary function testing, and a transthoracic echocardiogram. And of course, we sent her with precautions that if she were to ever feel her symptoms worsen suddenly, to present to the nearest emergency department. So as I stated, following that clinic visit, there was a plan for additional workup as well as follow-up. So as planned, pulmonary function testing was completed and normal, as was a transthoracic echocardiogram. However, also in the time period between her initial clinic visit and what would be her follow-up clinic visit, she continued to experience symptoms with 2 episodes so severe that it would prompt her to present to the emergency department. Over the course of those visits to the emergency department, she would have a normal chest x-ray, a normal CT angiogram of her chest, a normal CT abdomen pelvis. She even had blood gas, and blood gas on room air was also unremarkable. So from each of those visits, she would be discharged without a definitive diagnosis. And so that brings us to her second clinic visit, which was about 6 weeks after her initial presentation. So in the time since that first presentation, she reported the persistence of her symptoms, which continued to really honestly perplex us. And then vitals during that current clinic visit were notable for tachycardia and tachypnea, but again, without hypoxia. She did appear to be in some distress. She was leaning in a semi-tripod position. She appeared uncomfortable. She was speaking only in short sentences. But otherwise, cardiac exam was normal, except for the tachycardia, and her pulmonary exam revealed no adventitious breath sounds, and she had a benign thyroid exam. Lab work that was obtained during that visit, as before, was all unremarkable, including normal blood count, chemistries, and thyroid studies. So just to pause and kind of recap here, so we're about a total of 3 months into symptoms with a very thorough negative workup up to this point, including labs, imaging, which included that chest x-ray, CTs, and yet the patient continued to be very clearly be experiencing these symptoms, which was understandably distressing. So ultimately, with additional probing, we reached a final diagnosis of panic disorder with agoraphobia. There were clues in her history that hinted towards this. Notably, when we asked about exposure, she did deny them, mentioning she didn't really leave home all that much, but it was only after that diagnosis that the association of her symptoms and leaving home became more clear, though initially we thought the leaving home component and having symptoms might mean there was some exertional component to her symptoms. But this diagnosis of panic disorder with agoraphobia can only be reached because of thorough workup that was done, which leads me to my discussion points for this case. So the first takeaway is to remember how broad a differential there is for dyspnea. And because of that broad nature, we have to take a detailed history. We have to partner that with careful diagnostic workup in order to guide clinicians towards the proper diagnosis. Most commonly, the etiologies include those diagnoses with underlying cardiovascular components or pulmonary components in addition to endocrinopathies. However, we must also remain cognizant of other possibilities like neurological disease or, as in this case, underlying psychiatric disease. Importantly, and this is a point I would really like to stress, is that for those diagnoses with underlying psychiatric disease, it absolutely must be approached as a diagnosis of exclusion. Because while a psychiatric history may help guide additional considerations, it shouldn't on its own narrow and eliminate other possibilities, because missing such diagnoses could be detrimental. And before I end and open the floor to any questions, I want to address something that might be something that many people are wondering, which is, how did the patient feel about this diagnosis? And honestly, she was relieved, and we could physically see that when we told her. She even had tears in her eyes, thanking us for our work. Her symptoms were real, and we validated her on that. And the lack of explanation for her symptoms was obviously terrifying and distressing for her. But she appreciated the thorough workup and the attention that we paid that led to an answer, which I think brings us back to remembering the importance of not only the science of medicine, but the art of it. It was by being thorough, by paying close attention, and by listening and not making assumptions to this patient, we were able to bring the kind of healing we so desire for all of our patients. Thank you.
Great. Thank you so much, Amanda. Was there anything interesting in this patient's social history that may have clued you into psychological basis?
No, she had this underlying, she had this diagnosis of anxiety that wouldn't come out until later. The only thing that kind of came out was that she didn't really leave home much, but we attributed that to, like I mentioned, just perhaps having an exertional component to it. But, I think, looking back, kind of playing Monday morning quarterback here, it seems like that would be the big clue into, hey, something is a little, might warrant further investigation here, this fact that she didn't leave home. Yeah.
Did she have any follow-up?
So she followed with us up to that point, and actually what she didn't have was follow-up in the emergency department. So that was actually really good to see, was that she, we can expect that she continued to experience these symptoms, but we didn't see her have to present to the emergency department again, which was, I think, a testament to, her getting that answer, and her didn't take the symptoms away, but it did deliver a level of healing, and just in terms of her kind of knowing where this is coming from. And so we followed up with her an additional time, and then after that, she was kind of lost to follow up. But what we were happy to see is that she wasn't continuing to present to the emergency department.
Mm-hmm. And last question from me. As far as management of this patient, was she currently on any SSRI or SNRI, or currently undergoing any therapy for her prior diagnosis?
So that diagnosis, that kind of additional psych history, was not something that we were aware of. It was not something the patient was aware of. It was undiagnosed. So she was not on SSRIs. I will say that during during her second clinic visit, after we had established diagnosis, we did teach her some deep breathing techniques in clinic, which did seem to help the acute episode. And we expect that that's something that she had continued to take with her. So we actually did not start her on those things. We were teaching her kind of how to work through that in that initial period.